This is Advanced Pharmacology Study Notes, all the GI stuff. Feasible pharmacotherapeutic alternatives to treat GERD symptoms include antacids. They increase the pH of the gastric refluxate by neutralizing gastric acid, thereby decreasing its potential to cause damage to the esophageal mucosa. These agents also increase the LES tone through alkalinization of gastric contents. In patients whose symptoms are relieved with antacids, relief generally occurs within 5 to 15 minutes after administration and may last for 1 to 3 hours depending on the rate of gastric emptying. The short duration of action necessitates frequent dosing. Patients taking antacids for relief of GERD symptoms may need 4 to 5 doses throughout the day for adequate symptom relief. Antacids are considered first-line therapy for managing patients with mild intermittent symptoms of GERD without esophagitis. They may also be used for breakthrough symptoms in patients receiving H2 receptor antagonists or PPIs. When prescribing or recommending antacid therapy, careful consideration should be given to the adverse effect profile of the agent as well as the potential for drug interactions. Patients with chronic kidney disease may be at risk for accumulating both magnesium and aluminum, both of which are commonly used in antacid products. Calcium-based antacids are a viable option and should also be used for patients with CKD who have hyperphosphatemia. However, they also require frequent dosing. Alginic acid dissociates to form a neutral substance, sodium alginate, which floats on the top of the gastric contents, thus creating an anti-reflux layer and abolishing or displacing the postprandial acid pocket. Theoretically, the sodium alginate is refluxed instead of gastric acid, and esophageal irritation is maximized. Alginic acid, antacids such as Gaviscon, is a combination product that, similar to antacids alone, can be used for symptom relief in patients without esophagitis. Studies evaluating alginate plus antacid to placebo demonstrated superiority of the alginate and acid in relieving heartburn. However, no studies have shown superiority of the alginate and acid combination over antacid alone. Additionally, the combination product is generally more expensive. Sulcorphate, a mucosal coating agent that forms a protective barrier between esophageal tissue and gastric refluxate. It preferentially binds to ulcerated tissue, preventing penetration of acid. Sulcorphate also possesses cytoprotective effects, including stimulation of prostaglandin production and enhancing blood flow to the mucosa. Although it does not have FDA-approved labeling for the treatment of GERD, sucralfate has been demonstrated to provide symptom relief and esophageal healing. However, its role is limited to use in cases of mild to moderate esophagitis. Combination therapy with acid suppressive agents or symptomatic treatment in pregnant patients. The agent should be administered in a liquid formulation for the treatment of GERD to make contact with esophageal tissue. In addition, sulforaphate must be administered at least 4 times a day, 1 hour before meals and at bedtime, making patient adherence difficult. As sulforaphate contains aluminum, it is not recommended for long-term use in patients with CKD. H2RAs, so cimetidine, ranitidine, famotidine, and nizatidine, are acid suppressive agents that inhibit stimulation of the gastric parietal cell by histamine. The four commercially available products are equally effective when used in equivalent doses. All of the products are available in OTC dosage formulations. Low-dose OTC formulations are considered first-line therapy for mild or infrequent GERD, symptoms without esophagitis. They are useful when taken before an activity that potentiates reflux symptoms such as eating or heavy meal or exercising. Prescription strength famotidine and ranitidine are available on an OTC basis. Famotidine 10 milligrams is also available as a combination product with calcium and magnesium-based antacid. That would be Pepsid Complete. Standard dose regimens administered in divided doses, while superior to placebo in healing esophagitis, are inferior to PPIs and thus are not recommended as first-line options. Symptom relief is experienced by up to 50 to 70% of patients treated with H2RAs, and healing rates of endoscopically confirmed esophagitis may be up to 41%. Healing rates with H2RAs are inversely related to the severity of the disease and increase with prolonged duration of therapy, i.e. 12 weeks. However, long-term use of H2RAs may be associated with development of tachyplexus and loss of effectiveness. Of the available agents, cimetidine is associated with the highest incidence of side effects when used in higher doses or when administered to patients with renal impairment, patients with hepatic impairment, and older adults. Also, it is a known inhibitor of phase 1 oxidative metabolism, therefore is associated with numerous CYP450 mediated drug reactions. PPIs, omeprazole, linacapril, rabeprazole, pantoprazole, esomeprazole, and dexlansoprazole irreversibly bind to the hydrogen potassium ATPase pump of the parietal cells, thereby inhibiting the final step of acid secretion. Esophageal healing is related to the degree and duration of gastric acid suppression because they inhibit the final common pathway for gastric acid secretion. PPIs are more effective at suppressing acid secretion than H2RAs. Omeprazole and lansoprazole are available in OTC formulations. Long-term use of PPIs is not typically associated with the development of tachyphylaxis and loss of effectiveness. The PPIs have been demonstrated to be more effective than H2RAs for symptom relief and esophageal healing in patients with esophagitis. A PPI is generally considered the drug of choice for patients with erosive esophagitis. The once daily dosing with PPIs offers an advantage over high dose H2RA therapy in terms of cost and patient compliance when used at equivalent doses. PPIs are considered equally effective. However, some data suggests better efficacy for esomeprazole in grade C and D esophagitis. Oral once daily PPI regimens for treatment of erosive esophagitis include the following: Prevacid 30 milligrams, Nexium 20 milligrams, Prilosec 20, Zegerid 20, Protonix 40, Acifex 20, Dexilent 60 milligrams. The omeprazole sodium bicarbonate product formulation contains sodium that may worsen her hypertension and is therefore not a preferred therapeutic option. Prokinetic agents improve esophageal peristalsis and increase LES tone. Through such actions, prokinetic agents enhance luminal clearance and gastric emptying, and also reduce the duration and frequency of reflux. Metoclopramide is a dopamine antagonist that increases LES pressure and accelerates gastric emptying. It also is associated with troublesome side effects including drowsiness, restlessness, drug-induced Parkinsonism, and tardive dyskinesia. A warning from the FDA cautions against the long-term use of metoclopramide due to its association with development of tardive dyskinesia. Metoclopramide generally is considered less effective than H2RAs for symptom relief and esophageal healing, and requires dose adjustment for renal disease. Erythromycin is a macrolide antibiotic that acts as a motilin agonist to accelerate gastric emptying time. It can be used as an alternative to metoclopramide. However, long-term use is often associated with development of tolerance and loss of efficacy. Patients may experience dyspepsia and diarrhea as adverse effects. Drug interactions involving the CYP450 system may also occur with erythromycin. Baclofen, an GABA antagonist, has been shown to reduce the frequency of transient LES relaxations. Studies have demonstrated reductions in reflux episodes up to 48%. However, the common side effect of dizziness and nausea and the frequency of administration 3 to 4 times daily may limit the clinical usefulness of this agent. Neuromodulators are CNS active medications such as tricyclic antidepressants, selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, and trazodone that may be used in cases of refractory GERD in patients with functional esophageal disorders who are failing optimized anti-secretory therapy. They work primarily to reduce esophageal pain by modulating central and peripheral hyperalgesia. Patients often require further diagnostic testing to rule out other esophageal disorders prior to prescribing as data are limited and many of these agents may have significant adverse effects. Information should be provided to the patient to enhance compliance, ensure successful therapy, and minimize adverse effects. This might include implementing lifestyle and dietary modifications. It may help reduce the frequency and severity of your symptoms, although the recent treatment guidelines indicate that alteration in diet may yield relatively small results. I recommend that you try to avoid alcohol and certain foods such as caffeine, fried and fatty foods, and spicy foods that can make symptoms worse. Avoid eating within 2 to 3 hours of lying down or going to bed. If possible, purchase a foam rubber wedge 6 to 8 inches high and place it on top of your mattress and under your head and chest while you sleep. This may decrease the amount of symptoms you experience at night. You are encouraged to maintain a symptom diary that records the time you have symptoms, the type of symptom that you have, and any things that may have triggered the symptoms. Also record any use of antacids for symptom relief. Please contact your healthcare provider immediately if you experience bleeding difficulty or pain when swallowing. PPI. This medication is being used to decrease the production of stomach acid, which can reflux up into your esophagus, causing the symptoms of heartburn and coughing that you have been experiencing. This should also help heal the erosions in your esophagus. Take this medication by mouth once a day, 30 minutes before your first meal of the day. Swallow the capsule or tablet whole if possible. Do not crush or chew the capsule or tablet. If you have difficulty swallowing it, you may open the capsule and mix the contents with applesauce or with apple, orange, or cranberry, grape, or tomato juice. Do not take this medicine at the same time that you take any antacids. You will be taking this medication for 8 to 12 weeks. After that time, your doctor will evaluate your need for further therapy. You will most likely need to continue a lower dose of the same medication for several weeks or months to prevent your symptoms from returning. Although this medication is usually well tolerated, some patients experience minor side effects such as stomach pain, constipation, and headache. However, if you develop diarrhea that persists or muscle spasms, shakiness, or seizures, please report this to your healthcare provider. Your healthcare provider may wish to check your blood levels of magnesium periodically while you are receiving this medication. Clinical and laboratory parameters should be used to evaluate the therapy for achievement of the desired therapeutic outcome and to detect or prevent adverse effects. In terms of efficacy, ask the patient on follow-up if he or she has experienced relief of their symptoms of postprandial heartburn, regurgitation, and nocturnal reflux, and coughing episodes. If symptoms are improved, repeat endoscopy is not recommended to evaluate disease progression. Evaluate patient adherence with the prescribed medication regimen. Determine how often the patient uses antacids for relief of symptoms. Assess for improvement in the patient's quality of life, including reduction in pain and reduced or eliminated nighttime awakenings, reduced coughing episodes, and improvements in sleep and daytime fatigue. In terms of adverse effects, although PPIs are generally well tolerated, the most common adverse effects are GI nausea, vomiting, diarrhea, constipation, and abdominal pain, headache, and dizziness. Chronic PPI therapy may decrease the absorption of cobalamin. The risk is higher in patients with continuous use greater than 3 months. Therefore, periodic monitoring of vitamin B12 levels may be reasonable in patients receiving long-term therapy, especially the older adult, patients with poor nutritional intake, or those with evidence of anemia. Some concern has been raised that long-term PPI use may predispose patients to pulmonary or GI infections. The PPIs have been associated with a roughly twofold increase in C. diff infections. All prescription strength PPIs now carry a warning that patients are predisposed to a development of C. diff infections and should report persistent diarrhea to their healthcare provider. Clinicians can consider testing patients receiving PPIs for C. diff infections who present with persistent diarrhea. While increases in pulmonary infections have been reported in some studies, the overall risk is low. Recent data suggests the risk of community-acquired pneumonia may be elevated in the short term but not long term. Patients should be evaluated for preventative measures such as eligibility for the pneumococcal vaccine. Studies have shown association between PPI use and development of fractures. However, significant reductions in bone mineral density have not been observed. This increased risk has been added to the labeling for prescription PPIs as a potential long-term complication. Patients should routinely be reassessed for the need for continued PPI, especially if they are at risk for bone loss, and the lowest effective dose should be used. Further discussion on this topic is presented below in relation to the patient's question regarding whether she should take calcium and vitamin D. PPIs have been associated with development of hypomagnesia. Risk for this adverse effect has been added to the prescription strength PPI labeling. This may be due to reduced absorption of magnesium and may predispose patients to the development of neuroleptic adverse effects such as tremors, tetany, or seizures. Patients receiving other drugs that result in development of hypomagnesia, such as diuretics, may be at higher risk when concurrently receiving a PPI. Likewise, toxicity of drugs such as digoxin may be enhanced in the presence of hypomagnesemia. Consideration can be given to obtaining baseline serum magnesium concentrations with periodic monitoring, particularly in patients receiving diuretics or digoxin. Interstitial nephritis and acute kidney injury have been reported with PPI use, as well as concerns for development of dementia with long-term use. No specific monitoring is recommended at this time. However, patients should be evaluated as symptoms arise. This patient should have intermittent monitoring of renal function anyway due to her diabetes. All right, that was his stuff on that he put in for the case study. Since he put it twice, I thought it would be important. Okay, so here are the actual notes. C. diff infection. FDA's analysis of over 28 studies revealed that patients taking PPIs were at a 1.4 to 2.7 times greater risk of developing an infection. Fractures. FDA reviewed several studies and have concluded that PPIs in high doses, multiple daily doses, and or continued therapy for longer than a year increase a person's risk of osteoporosis related fractures. Magnesium. PPIs may decrease magnesium level, which can lead to muscle spasms, arrhythmias, seizures, and fatigue. This typically occurs after long-term administration of PPIs, usually longer than a year. Treatment may require magnesium replacement and PPI discontinuation. Dementia. Although several theories exist to possibly explain the mechanism, the association needs to be validated in large cohorts and tested in case-controlled studies. For now, it is possibly safe to say a causal link is plausible. H. pylori infection causes gastritis, PUD, gastric cancer, and mucosa-associated lymphoid tissue, MOUT. Lymphoma and the association between the presence of H. pylori and NSAIDs. An increased incidence of PUD is well documented, but is all of this clinically meaningful? Patients with known osteoporosis can remain on PPI therapy. Concern for hip fractures and osteoporosis should not affect the decision to use PPI long-term except in patients with other risk factors for hip fracture. With the exception of non-clostridioids difficile enteric infections, after a median of 3 years of use, PPIs did not increase the risk of chronic kidney disease, dementia, bone fracture, MI, pneumonia, micronutrient deficiencies, and GI cancer. The authors concluded that PPI therapy is safe for up to 3 years and that limiting prescription of PPI therapy because of concerns of long-term harm is not warranted. GERD. Heartburn is the hallmark symptom. May be associated with significant morbidity, may be associated with atypical or alarm symptoms. Treatment goals: relieve associated symptoms, promote esophageal healing, avoid complications, prevent recurrence. Step 1. Lifestyle modification, non-pharmacological interventions, such as dietary modification, avoid contributing medication, smoking cessation, avoidance of ETOH, weight loss, etc. Elevate the head of bed 6 to 8 inches, dietary changes, weight reduction, avoid contributing medication, smoking cessation, avoid of alcohol, avoid tight-fitting clothing, remain upright 30 minutes after eating. There are simply too many recommendations, and each is too narrowly applicable to enforce the whole set on every patient, and routine global elimination of food that can trigger reflux is not recommended in the treatment of GERD. However, it is also clear that there are subsets of patients who may benefit from specific lifestyle modification, and it is good practice to make those recommendations to those patients based on specific history. Antacids are multivalent cations with many precautions. drug interactions and adverse effects. Note comments section below. Use as needed for mild GERD for immediate relief, short term, not indicated for chronic use. Clinically significant drug interactions, binding and altered absorption of drugs. Step 2, lifestyle modification with standard dose acid suppression therapy. In red, note there is no significant difference in efficacy among the H2RAs when given at equipotent doses. Cimetidine is associated with numerous clinically significant drug interactions. This is not the case with other agents within the class. Dose reduction in renal and hepatic insufficiency and in the elderly. Duration of suppression ranges from 6 to 10 hours and varies with dose. In red, note there is no significant difference in efficacy among the PPIs when giving at equipotent doses. Food may affect absorption given 30 to 60 minutes before a meal. More flexibility in long term of dosing with newer gut agents. Delayed onset 3 to 4 days for full inhibition. Duration of action up to 24 hours due to covalent irreversible inhibition of proton pump. Step 3, PPIs for 4 to 16 weeks. PPI therapy should be initiated at once a day dosing before the first meal of the day. For patients with partial response to once daily therapy, tailored therapy with adjustment of dose timing and or twice daily dosing should be considered in patients with nighttime symptoms, variable schedules, and or sleep disturbance. In patients with partial response to PPI therapy, increasing the dose to twice daily therapy or switching to a different PPI may provide additional symptom relief. Step 4 is surgical intervention. Maintenance PPI therapy should be administered for GERD patients who continue to have symptoms after PPI is discontinued and in patients with complications. There are many risks. Final thoughts on GERD. Therapy for GERD other than acid suppression includes prokinetic therapy and or baclofen. Should not be used in GERD patients without diagnostic evaluation. For patients with partial response to once daily therapy with a PPI, tailored therapy with adjustment of dose and timing and or twice daily dosing should be considered in patients with nighttime symptoms, variable schedules, and or sleep. In patients with partial response to PPI therapy, increasing the dose to twice daily therapy or switching to a different PPI may provide additional symptom relief. Maintenance PPI therapy should be administered for GERD patients who continue to have symptoms after the PPI is discontinued, and in patients with complications including erosive esophagitis and Barrett's esophagitis. Histamine receptor antagonists, H2RA therapy, can be used as a maintenance option in patients without erosive disease. If patients experience heartburn relief, bedtime H2RA therapy can be added to daytime PPI therapy in selected patients with objective evidence of nighttime reflux if needed, but may be associated with the development of tachyphylaxis after several weeks of usage. PUD. Peptic ulcers, gastric and duodenal, are defects in the GI mucosa that extend through the muscularis mucosa. Causal relationships associated with H. pylori infection, NSAIDs, and SRMD. Therapy includes non-pharmacological interventions similar to GERD and pharmacological with acid suppression and mucosal protection, sulfurate, colloidal bismuth, misoprostol, if present H. pylori eradication. Acid suppression. See treatment modalities under GERD. Mucosal protection. Sulfurate, sucralfate in acid environment, it turns into a viscous, sticky polymer that binds selectively to ulcers and erosions, creating a protective layer. Efficacy is comparable to H2RAs. It chemically contains aluminum, thus behaves as aluminum as far as adverse drug reactions such as constipations and drug interactions such as chelation. Bismuth coats ulcers and erosions, creating a protective layer against acid, and pepsin may stimulate PG and mucus secretion and binds bacterial endotoxins and has direct antimicrobial activity against pylori. Misoprostol, it stimulates mucus and bicarbonate secretion, replaces PG stores, and enhances mucosal blood flow. Approved for prevention of NSAID-induced ulcers in high-risk patients. H. pylori eradication. Because of the critical role of H. pylori in the pathogenesis of peptic ulcer, eradication of this infection is a standard care in patients with gastric or duodenal ulcers. In red, all regimens include 2 antibiotics and acid suppression therapy, PPI or H2RA. It may include bismuth preparation. In patients aged 55 years or younger with no alarm features, the clinician may consider 2 approximately equivalent management options. 1. Test and treat for H. pylori and a trial of acid suppression if eradication is successful but symptoms do not resolve. Or 2. An empiric trial of acid suppression with a proton pump inhibitor, PPI. NSAID-induced ulcers. This is in red. Prevention. Misoprostol or PPI, H2RAs are not recommended for prophylaxis. COX-2 inhibitors are associated with a significantly lower incidence of gastric and duodenal ulcers when compared to traditional NSAIDs. However, this beneficial effect is negated when the patient is taking concomitant low-dose aspirin. The usefulness of these agents has also been reduced by their association with myocardial infarction and other thrombotic CV events. COX-2 inhibitors and NSAIDs to be discussed in more detail later in the semester. Candidate for prophylaxis. History of prior GI event. Age over 60, because that's 5 times greater risk. High NSAID dosage. Concurrent use of corticosteroids, 4 times greater risk. Concurrent use of anticoagulants, antiplatelet or low dose aspirin, 12 times greater risk. Treatment. Discontinue NSAID if possible. Eradicate H. pylori if possible. H2RAs or PPIs. PPIs heal NSAID-related ulcers more effectively as compared with H2RAs and are therefore the anti-secretory drug of choice for treating NSAID-related ulcers, especially when NSAIDs are continued. Patients with NSAID-associated ulcers should be treated with a PPI for a minimum of 8 weeks. Sucralfate is an option for healing only if NSAIDs will be stopped. Stress ulcer prophylaxis. The American Society of Health System Pharmacists recommends prophylaxis in the following scenarios. Coagulopathy, defined as a platelet count less than 50,000. Mechanical ventilation for longer than 48 hours. History of GI ulceration or bleed within 1 year before admission. Head or spinal cord injury. Burns on more than 35% of the body surface area. ICU patients with multiple trauma. Transplant patients perioperatively, and patients with at least 2 of the following risk factors: sepsis, ICU stay longer than 1 week, occult bleeding for at least 6 days, and use of high-dose corticosteroids. As of now, there is no current recommendation for PPIs over H2RAs, as further clinical studies, including pharmacoeconomic analysis, are needed. Proton pump inhibitors versus histamine 2 receptor antagonists for stress-related mucosal bleeding, prophylaxis in critically ill patients, a meta-analysis. I'm reading his reference. In the United States, pantoprazole is the most common PPI prescribed for stress ulcer prophylaxis. Although there are no comparative data among PPIs to suggest one is superior to another, similarly, there are no data comparing H2 blockers with one another. In reality, within a chosen class of prophylactic agents, many clinicians prescribe an agent that is determined by the hospital or pharmacy policy. In rare cases where PPIs or H2 blockers cannot be administered, so sucralfate is suitable oral alternative. All right, now this is in red. Approach to treatment should begin with determination of cause. So, opiates, anticholinergics such as tricyclic antidepressants, amitriptyline, diphenhydramine, benzotropin, NDHD, CCB such as verapamil, oral iron preparations, calcium or aluminum antacids, NSAIDs, clonidine, diuretics. Non-pharmacological interventions first, so diet, fiber, exercise, fluids, probiotics, limited data on them. Pharmacological bulk forming agents, so like Citracel. Administer 240 milliliters of water with each dose to prevent esophageal GI obstruction and worsening symptoms. Physical binding of other substances, including medication, safe in pregnancy. Oh, sorry, we're on constipation now. So all of those reasons were reasons for constipation. I'm just reading along. Emollients, softeners such as colace, docusate, facilitates mixing of aqueous and fatty materials in the intestinal tract, used for prevention, not treatment, commonly prescribed with medications that may cause constipation, so chronic opiate use, iron supplementation, etc., and it's safe in pregnancy. Lubricant laxative, so mineral oil or castor oil, coats the stool to allow easy passage, prevents colonic water absorption, systemic absorption can generate immune response, aspiration may lead to lipoid pneumonia, decreased absorption of fat soluble vitamins, and do not use in pregnancy. That's in red. Hyperosmotics, so like glycol, so like Miralax, osmotic effect to retain fluid in GI tract. In red, it's safe in pregnancy. Saline laxatives, composed of relatively poor absorbed ions, magnesium sulfate, phosphate, citrate, so e.g. milk of magnesia, osmotic effects to retain fluid in GI tract, may be used occasionally to treat constipation in otherwise healthy adults. Adverse drug reactions, fluid and electrolyte disturbances, magnesium renal dysfunction, or sodium and CHF accumulation. Stimulant laxatives, Senna, Biscodil, Senecot, Docalox. Only recommended for intermittent use. Daily use is strongly discouraged. New agents available for specific use only. Not discussed in this course. So why is it in our notes? Summary of recommendations: slow transit, constipation, hyperosmotic laxatives, Senna, Biscol, and other stimulants are second line. Those who need to avoid straining, hemorrhoids, hernia, MI, stool softeners, or PEG. Children, diet, fluid, exercise. Avoid under 6 years olds without evaluation. Glycerin, suppository, or docusate, like colace is fine. Diarrhea. Diarrhea is a symptom of an underlying problem, not a disease. Diarrhea that lasts less than 2 weeks is termed acute diarrhea. Persistent diarrhea that lasts between 2 and 4 weeks. Chronic diarrhea lasts longer than 4 weeks. These are in poisoning, food intolerance, infectious, bacterial, viral, or protozoal, acute chronic illnesses, or medications. This is in red. The goal of treatment is to identify and treat primary cause, manage secondary causes, prevent electrolyte and acid-base disturbances and dehydration, provide symptomatic relief. Note, the primary goal is not always to stop diarrhea. See below infectious diarrhea. Non-pharmacological, rehydration, oral preferred. Avoid soda products, Gatorade, chicken broth, tea. Diet. Resume age-appropriate diet once rehydrated. Again, this is in red. Secondary causes can include medications. An evaluation of medications and possible substitution of offending medication should be considered if possible. Magnesium-containing antacids, metformin in about a third of the patients. Antibiotics, about a 25% incidence. Anti-inflammatory, anti-gout, such as colchicine, etc. Pharmacological agents. Anti-diarrheal drug therapy can be helpful to control severe symptoms and includes bismuth, subsalicylate, and anti-motility agents such as loperamide. These, however, should be avoided in people with high fever or bloody diarrhea, as they can worsen severe colon infections, and in children because the use of antidiarrheals can lead to complications of hemolytic uremic syndrome in cases of Shiga toxin or E. coli. Opiates and derivatives acts on peripheral, e.g. loperamide or Imodium, and central, diphenoxylate atropine, Lamodal, opioid receptors depending on the agent. Those that act on central mu receptors are controlled substances and prescription only. Non-infectious diarrhea, acute and chronic, adverse effects, constipation, fatigue, dizziness. Absorbance works through non-selective absorption, providing bulk in digestive tract, not systemically absorbed, binds 60 times its weight in water, also used for constipation, absorbs water and fluids, can also bind drugs leading to altered drug bioavailability. Bismuth, subsalicylate. Contraindications are aspirin allergy, nursing or pregnant women, GI bleeding, immunocompromised patients. Drug interactions decrease protein binding of warfarin, decrease absorption of TCN and quinolones. Oxyutride prevents the release of secretory substances, stimulates intestinal absorption. Symptomatic treatment of carcinoid tumors and VIPomas that produce violent watery diarrhea. Adverse effects: nausea, abdominal pain, QT prolongation. Cholelithiasis, hyper or hypoglycemia. Crofelemer, FDA approved for symptomatic relief of non-infectious diarrhea in patients with HIV and AIDS and on antiretroviral therapy. Probiotics help maintain normal GI flora, reduce colonization of disease-causing bacteria. Evidence vary based on intended use, strain of bacterium, and timing of administration. Digestive enzymes such as lactate, used in patients with lactase deficiency who are lactose intolerant. This is in red. We do not routinely use empiric antibiotics on patients with acute diarrhea. Infectious diarrhea, so C. diff. The initial step in treatment of C. diff is cessation of the inciting antibiotic as soon as possible. Treatment with concomitant antibiotics is associated with prolongation of diarrhea, increased likelihood of treatment failure, and increased risk of recurrent C. diff. Therapy for non-severe C. diff infection consists of oral metronidazole and oral vancomycin. Limitations of metronidazole include dose-dependent peripheral neuropathy and side effects of nausea and metallic taste. Use of oral vancomycin is appropriate for initial therapy of non-severe disease in patients who are pregnant, breastfeeding, or intolerant, allergic to metronidazole. Rifaximin small case series have suggested that sequential therapy with vancomycin followed by rifaximin may be effective for treatment of recurring CDI. Anti-motility agents such as loperamide, diphenoxylate atropine have traditionally been avoided in CDI, but the evidence that they cause harm is equivocal. Anti-motility agents have traditionally been avoided in CDI, but the evidence that they cause harm is equivocal. Traveler's diarrhea. The classic traveler's diarrhea due to enterotoxigenic Escherichia coli generally produces malaise, anorexia, and abdominal cramps, followed by the sudden onset of watery diarrhea. The illness is generally self-limited, with symptoms lasting for approximately 1 to 5 days. This is in red. Antibiotics are warranted to treat diarrhea in those who develop severe diarrhea characterized by more than 4 unformed stools daily, fever or blood, pus or mucus in the stool. In addition, some travelers desire antibiotic treatment for milder disease if the illness is a large burden on a business trip or vacation. For mild to moderate disease, anti-motility drugs such as loperamide may be used as monotherapy. For severe disease, anti-motility drugs such as loperamide may be used cautiously as adjunctive therapy. Use in combination with simethicone anti-gas, so Mylicon or Gas-X may provide faster relief of symptoms. For adults, several different antibiotic options are effective for traveler's diarrhea. In general, fluoroquinolones, such as ciprofloxacin, are the first choice for their efficacy and tolerability. However, for travelers to Asia, azithromycin is preferable because of increasing resistance to fluoroquinolones among enteric pathogens in that region. Azithromycin is also preferred agent for pregnant women and children. We only use rifaximin if a fluoroquinolone or azithromycin is not available or appropriate because its efficacy for invasive disease is unknown. Nausea and vomiting. When choosing an agent, focus on individual patient, evaluate risk factors, and rule out other causes. Age-related variables, efficacy, ADRs, cost, etc. Please review mechanisms, ADRs, and indications. Example, promethazine. Block DA2 receptors in the CTZ plus have antihistaminic and anticholinergic effects. ADRs, EPS, sedation, and hypotension. Its place in therapy, and this is in red, its general purpose antiemetics. Not very effective in severe nausea and vomiting, such as chemotherapy induced. Example, lorazepam. Benzodiazepines bind to GABA A receptors. GABA is the major inhibitory NT in the CNS. Benzo neurotransmitter in the CNS. Benzodiazepines are sedatives, not antiemetic agents. Sedative and anxiety effects reduce, and this is in red, anticipatory nausea and vomiting associated with chemotherapy. So lorazepam does help nausea and vomiting in chemotherapy. Adverse drug reactions, CNS, sedation, hallucination, euphoria, CV, hypotension. We know that. CNV, evaluate emetogenic potential of regimen, monotherapy for chemotherapy with low and moderate emetogenic risk, aggressive, combination of agents with different mechanisms, antiemetics for highly emotogenic regimens, and delayed CINV. Examples: dexamethasone plus metoclopramide plus diphenhydramine plus lorazepam, or ondansetron plus dexamethasone, or ondansetron plus metoclopramide, or metoclopramide plus dexamethasone, or ondansetron plus dexamethasone plus chlorchlorpromazine, etc. And that's it.